My name is Sandy McConaughey, and I am the president of the BC Lymphedema Association. And our vision is that patients with lymphatic disorders will have medical access to early diagnosis, education, and compression in all health regions of the province. Check out our website for upcoming events. And if you're interested in joining, we're all volunteers, so really appreciate that. So our webinar today is with Dr. Brown from the VGH UBC Lymphedema Clinic. The clinic was opened in January 2020 with Dr. Elliot Weiss, who's a physiatrist, Dr. Catherine Isaac, a plastic surgeon, and Dr. Aaron Brown as physician leads for this provincial program. Dr. Elliot Weiss had been caring and advocating for lymphedema in BC for decades and recognized this potential for enhanced surgical management. Also, the Division of Plastic Surgery at UBC observed this gap in patient care and supported a sabbatical for Dr. Brown to travel to Japan, Korea, and Taiwan to receive exposure to world leaders in lymphedema reconstruction. Dr. Maura Stillwell, a radiologist and nuclear medicine physician, also redesigned the technique for lymphoscintigraphy, which has dramatically improved the ability to map out the lymphatic flow and function. Dr. Aaron Brown is the head of the Division of Plastic Surgery at UBC. His areas of interest include hand and upper extremity, peripheral nerve surgery, reconstructive microsurgery, aesthetic surgery, plastic surgery, trauma. I've gotten all this off the website, so if you want to add anything, Dr. Brown, go ahead. We really appreciate you being here today to answer questions about the program. We sent Dr. Brown some questions in advance, so we will be going through those first. But please, as we're going through them, if you have questions, please enter them into the chat box at the bottom of your screen. And hopefully we've been able to admit everybody here. We've got 57 people attending, so, and more all the time. Do you want to say anything before we start, Dr. Brown?
No, just thank you all for making the time. I'm in the operating room right now, but I'm happy to chat. And I'll just say, I guess the goal of the clinic in my mind is to try to provide the best scope of available treatment options from a surgical and non-surgical perspective. And when we see people in consultation, we are very frank about the fact that what we're doing today will be different than what's done in 5 years from now. And this is still an area in evolution. So our goal as care providers is to be receptive to new information as it presents itself, and to continue to grow and evolve as that new information becomes available. I'll also make just a generic comment, and that is that sometimes when we have difficult problems, it goes beyond lymphedema. Many times when we just have a challenge in our health, we're looking for the cure, or we're looking for the answer. And this is an area where there is no answer. There is things that can improve your situation, and sometimes even dramatically improve your situation. And what we try to do, our philosophy in the clinic, is to try to, and anybody who's had consultation with us will know that this is what we do. We really try to figure out what your specific goals are and try to match those to the available treatments. Sometimes people who've traveled abroad will find that they go to see someone who provides a very specific treatment, and that is a fairly homogeneous or cookie cutter approach. For a variety of reasons, their expertise in that area, or their remuneration for that procedure or whatever it may be. And we try very hard not to provide care based on what we can do, but rather what is hopefully the best thing for you. So that's just the general philosophy that we try to bring to this endeavor, which we try to bring to all of our patient care, but specifically for these patients that we see. And with that, fire away. I'm happy to answer any questions.
Okay, the first question is, how many surgeries do you perform each month, and what is the total to date?
Right. So I answered this question kind of generically. I perform a lot of surgeries every month. I said probably 30 to 50. Now, those are not all for lymphedema. My colleague is just finishing up one surgery that's been going on all day, not lymphedema. And I did a bunch of cancer surgeries this morning, also not lymphedema. So our lymphedema surgeries, which is I think what people are really asking, vary from month to month. I try my best to do those surgeries with Catherine so that we can both be contributing to this process. It doesn't always work out. Sometimes we'll do no surgeries for lymphedema in a month, and sometimes we'll do 3 or 4. It will really just depend on how things are going. We have to fit this in within the scope of the other things that we care for. So Catherine's a very busy breast reconstructive surgeon. And I do a lot of other microvascular reconstructions and hand surgery and surgery for people with spinal cord injury and other things. So it's maybe a little different again than some other places where people will focus exclusively on lymphedema, but that's just not in the cards for us right now. Nor do we have limitations in our operating time.
That really helps give us an idea. And the next question is, how long is the wait time to have surgery following completion of testing and consultations?
So for me, in general, unless you have a cancer or something, most people wait a year, sometimes longer. And it depends. Sometimes the surgeries are lengthy, like when we're doing lymph node transfers, those are a bit longer. The other thing that Dr. Isaac is trying to do, though, is to carve off some of her time so that she's specifically allocating some time for lymphedema surgery, and that may help us. In addition, we have 2 new surgeons who've joined our group in the last couple months, and both of them are interested in lymphedema surgery, and hopefully if we can get them involved, then that will also allow for more opportunities for patient care.
Thank you. If a person living in BC is diagnosed with lymphedema, but decides because of the wait times to go outside of BC to have testing and surgical treatment, what part, if any, would the person's GP and the VGH lymphedema program play in this scenario?
Yeah, likely little. I mean, we've certainly seen some patients that have had surgery done elsewhere. And often they're coming to see us because they haven't achieved the outcomes that they were hoping for. So we will obviously see them. But this is still an area where people have very specific ideas about how they would like patients managed after surgery. So we usually leave it to your primary surgeon to direct your care.
Okay, thank you. On our website, the BC Lymphedema Association, there's some confusion about the initial referral to see a doctor at the VGH lymphedema program. We're wanting to clear that up and clarify. So initially on our site, we said a GP could go and refer to the clinic. Can you talk a little bit about your wait times and what process makes sense these days? And we'll update our website to match that.
Again, this is an iterative process. So ideally, this process would be directed at the hospital level and not run through my office. So I'm basically running the program through my office. But the problem that we got into from a practical point of view is there's a tremendous backlog of patients waiting to be seen, as well as patients who are deeply concerned that they're going to develop lymphedema. So maybe they've just had surgery and they're contacting us for a referral because of concern that they want to get assessed early in case they might develop lymphedema. So that the volume of patients is very, very high. In addition to that, like most clinics of this nature, at least 20% of the patients that we see do not have lymphedema. They have heart problems or renal problems or obesity or many different medical issues that are important to be assessed and cared for, but they're not really within the scope or the mandate of our clinic. So as a result, we're trying to have many of the patients seen by Dr. Weiss because he's able to see them in a more timely fashion and then initiate non-surgical care and get their initial investigations underway. And as a result, by doing that, we are hoping to keep things moving along. I think it's entirely reasonable to update the referral process, but again, I imagine that this will again change in the future, particularly if we're able to have the hospital assume the management of this process. But that is a challenging process unto itself. All of these things are, I don't want to say you feel like Sisyphus pushing a rock up a hill, but it's a lot of work to get the healthcare system to embark upon new ways of patient care. But I think, yeah, it's really update that probably the best path right now is still through Dr. Weiss. And then whenever he refers somebody to the clinic, back to the clinic, we expedite that as best we're able.
Okay, thank you. We'll update our website also to say, if when I phone the office, there's a 2-year wait list to get in for a consultation at the moment, that maybe we'll suggest people to see a therapist at least once their GP or once Dr. Weiss has diagnosed for sure that it's lymphedema.
That's right.
And ruled out any of the other reasons for swelling.
Mm-hmm.
Are there other hospitals or clinics in Canada or elsewhere where a patient could have the ICG test done to help speed up the process? And who would provide a referral for the ICG test in this case?
Yeah, it's such an interesting question. I have no clue. And part of the reason I say that is my experience with how and maybe it reflects our medical system, maybe it reflects the philosophy that we bring to this clinic, but we really want patients to have the best and most comprehensive information available to direct the choices that they make. So for most patients, we perform lymphoscintigraphy and ICG, and in an ideal world, we would also get MRL, which is magnetic resonance lymphangiography. That is a tougher order, and we're still in the process of trying to get those tests initiated. Where I did my sabbatical, most of the time you would only get your ICG testing done immediately before surgery. It wasn't done in the same way. And part of the rationale for that, or part of the reason for that, was you were going to get LVA no matter what. Whether it was going to work or not didn't really matter. So you're going to get it. And that's a philosophical issue. It is very low morbidity. So lots of people will receive LVA, particularly if the surgeons are being paid very well to do it. But here we just do not have the resource to do a bunch of surgeries that don't really, if they're not going to work. We also don't, even if it's low morbidity, we want people to make the best choices and receive the best possible care. So as a result, we try to gather all of this information and let the patients understand, like, this is really not going to make a meaningful difference for you, or you might be a great candidate for this, so that they can then choose what's best. So what all that means is that if you went to Toronto or Montreal or Calgary, maybe some other places that are doing this, even if not through a formal clinic situation, they may just do your ICG at the time, right? When you're going to have surgery. So it's not often done just as a purely diagnostic test. It may be possible, and if it was, it would help us tremendously, because again, where I did my sabbaticals, the staff surgeons were not doing this. This is something that the residents and other people would do. It is a lot of extra work and time for us, but we really we want to provide the best possible information for the people in BC with lymphedema. So that's why we do it, and that we feel helps allow them to guide their decision-making process better. So I would be entirely accepting of that if there was another opportunity. I just don't know where that might be.
Thank you. Okay, I'm just going to back up a little bit for some of the people. I don't know everybody that's on this call, but just to clarify a few things. So typically you would see your doctor and they would rule out any other cases for swelling. A lymphoscintigraphy is a test that you inject dye where you can confirm that there's a blockage to the lymph system. And then please correct me if I'm saying this wrong, Dr. Brown. And then an ICG test is a little deeper. There's more information for the surgeon to know if there's any lymph vessels that are working well.
Yeah, they're both. I would say that, and there's some people feel that ICG is the only test necessary. Other people, there's still some mythology with this. They're complementary tests, I would say. The lymphoscintigraphy measures both the deep and the superficial lymphatics. So if anything is working, it should show how that progresses. ICG only can be visualized to 15 millimeters of depth. So if a person is very large, it may not be as accurate, but it provides a much more granular level of information. We can actually see the lymphatics. I think it's and again, if anyone who's had this done who may be on the call, it's really quite impressive to see your own lymphatics working. Or not working, as the case may be. So I think it provides a lot of meaningful personal information for the patients. But so I think of them as complementary tests to try to get a more holistic understanding of the lymphatic function.
And the MRL, can you just explain how that differs from the ICG and the other tests?
Yeah, if it's done well, it's a beautiful investigation. The gadolinium dye is again injected between your fingers or toes. So lots of injections into your sensitive spots. But then what it's able to do, like an MRI of your body in other ways, it's able to provide a three-dimensional picture of the lymphatics, and it can be very informative, either to show what's working or what might be possible to be used for surgical intervention.
Thank you. And then now we talked about LVA. Can you just describe the different types of surgeries that you use and sort of expand what that means for the people that may not understand what surgeries are available for lymphedema?
Sure. If I can share my screen, I'll go back. I have the talk that we gave before. I'll just kind of I'll just skip to that part and I'll explain it as we're talking, if that's okay.
Let me just set it up that you can share.
Let's just see here. I'll go to share screen.
Is it showing up as an option for you?
I think so.
Okay.
Let's make this here go to slideshow. There we go. Okay, I'm going to jump past a lot of this stuff. I'm happy to talk about anything. I also just want to make I'll make some general comments here. Your lymphatic system, for anybody, I'm sure you're all very, very aware of this, is just an important part of both your immune system and your circulatory system in returning fluid back to the heart. We think a lot about secondary lymphedema after surgery, usually after cancer surgery. But we do see many patients with primary lymphedema or lymphedema that has resulted from developmental problems in their body. And we have slightly different ideas about how that's best approached. I'm going to just jump by here to talk about these. And these are your lymphatics, they go from being normal to being dilated to being contracted and then sclerotic. And it's in the sclerosis and even the contraction phase that certain types of treatment are much less effective. And this just gives you some graphical representation of what a lymphatic can look like. These are very tiny and they're under microscope to see this. And if you're doing LVA, which I think there was a question about, you want them when they're slightly dilated is ideal. I'm just going to jump ahead here to actually show you the pictures. So what an LVA is a way of trying to redirect the lymph, because what the lymphatic system is doing is taking fluid that's leaked out and trying to return it to the heart. Often after things like breast cancer surgery or surgery where there's been surgery in your groin where the lymphatics have been disrupted, that natural pathway to return the fluid to your heart has been damaged. So you need to bypass that. And what we're trying to do to affect that change is to redirect that lymphatic fluid into the vein prematurely so that it can again return it to the heart. And it is technically demanding surgery, but it can be helpful. And part of the reason that people are keen to see us early is the understanding that as this condition progresses, that particular option becomes less effective. The one thing I will say is that the majority of the evidence for this suggests that the changes are generally modest. So a lot of the other surgery that I do is big surgery, big in the sense that the outcomes we're looking for are very functionally dramatic. In other words, someone who can't move their hand to moving their hand, someone who's going to lose their foot to someone who's going to save their foot. They're very demonstrable changes in a person's life. And this is something where sometimes patients will report, well, I feel like the limb is a bit softer, or I can wear a slightly smaller compression garment, but it's often not as dramatic. But that's how this works. The other sort of physiologic reconstruction that we do is to transfer tissue to the affected extremity to try and help that remove the excess fluid. And there's been many, many different ways that this has been tried. And my current reading of the best available evidence is we have moved to using tissue from inside the abdomen, the gastroepiploic tissue, to help in this process. And the reason I say that I think that this is the most helpful is the people who have this surgery have the highest probability of stopping compression. And to me, that is a fairly binary thing. Compression, no compression is a sign of real change to the individual. It's not a guarantee, doesn't always work. There's people who've had this surgery done elsewhere that fails altogether, but it is something that can be fairly dramatic. It's a more involved surgery. We get the general surgeon to help us using special scopes and things to harvest the tissue from inside the abdomen, and then we do the microsurgery on the outside to reconnect the tissue. I would also say this is probably the most effective treatment for people who have advanced lymphedema and for people who have congenital lymphedema. So again, it's also, I would say, from a technical perspective, it is much like the microsurgery that I've spent my whole career doing. The vessels are small, but they're well within the capabilities of any reasonable microsurgeon. And then the last thing and this is a non-physiologic treatment, and that's liposuction. And this is a very beneficial surgery. It can make a limb much, much smaller. So someone who says, oh my gosh, I can't go running, I can't do this or that because my limb is so heavy, it can make a dramatic difference. However, it is not insignificant. Even though the cuts on the leg are tiny, it causes a lot of swelling and discomfort early on. And some patients struggle with the compression, just like they did before, but they really find it problematic because we really stir up a lot of trouble in the early phase after the surgery. So it takes a number of months before you start to really realize the final outcome. And again, this goes to, again, what we talked about right at the beginning, and that is that we really try to tailor the treatments for what is best for the individual. So if someone says, I really hate the size of my leg, I can't find pants, I don't mind the compression, but I just really want it to be smaller and less heavy, liposuction is a great option. But it is not, it's not inconsequential to recover from. It still is a real surgery, and it takes time. So those are the three main treatment options. And then there's some others, some more aggressive or other things. I'm going to stop sharing so you can return to your questions.
Yeah, no, that was really helpful. And I think for the people that hadn't heard of what you offer and the different types of surgeries, that's really helpful. I guess a couple of questions that lead from that are, what arrangements are in place for follow-up and aftercare post-surgery?
Yeah, that's something that we struggle with. If you are local, and it's not, and I have to say, it's not just this part of my practice, it's for many parts of my practice. When you provide a provincial resource, people come from all over the province. And if you live in the Lower Mainland, it's quite straightforward for you to get back to us. We check on you frequently. We'll help you with your compression. We'll help you with bumps along the road if you have challenges. But just recently, there was a patient who had, a very extensive liposuction of her arm and returned to the interior and really had some challenges in trying to get the best post-operative care. We try our very best to ensure that everything is in place, but it's difficult. If you're far away, it means trying to organize this through phone calls and Zoom and trying to access that care from your home community, which is sometimes very good and sometimes more challenging.
Thank you. Do you complete liposuction and LVA or LVT on the same day?
Yeah, we haven't, but we certainly could. I think the biggest challenge is just, part of that is the length of the surgery. And also, for example, let's say someone has congenital lymphedema, they have a large limb, and they're not sure what exactly their goals are. If we can do liposuction, and if they're happy, we're done. If they're not fully satisfied and they feel like they want to make a change to the physiologic drainage from their leg, we can always do the vascularized lymph node transfer secondarily. It's also just a difficult thing. Liposuction is a fairly physical operation. To do something physical like that and then to go down and sit and work under the microscope is not, we can do it, but it's just not ideal. Usually we like to be not sweating and shaking from doing something very physical and then try to do something very delicate.
So the LVA and the LVT are microscopic and liposuction is not?
It is the opposite of microscopic.
Okay. If a patient wishes a copy of the scan and any diagnostic reports, how can they be obtained?
Yeah, that's totally fine. The ICG is a qualitative test. So when people come to see it, some people snap pictures of it. They're welcome to do that. It's not a secret. The patient's seeing it themselves. The other reports they can get either from their family physician or Dr. Weiss or myself or Dr. Isaac. It doesn't, none of this stuff should be secret. It's all your part of your medical record. Actually, and if you have your BC healthcare app, you can access it right then and there.
Great, thank you. In addition to living with lymphedema, what are the consequences to one's overall organ health and function from this disease? Like, do you have any?
I'm not sure I understand the question.
This was another one that sort of came in through the mail, so
Sorry,
I don't
could you say it again? I'll see if I can understand.
In addition to living with lymphedema, what effect does this have on one's overall organ health and function, like livers, kidneys, spleens? Does it affect the other organs?
I don't think it should be detrimental. I mean, the troubles are really generally in the extremity. If you had a congenital condition that was more broad, there might be an issue, but you know, your lymphedema unto itself shouldn't adversely affect your health. I mean, it affects it creates physical challenges for you, but it shouldn't affect your general health.
Thank you. Okay, I have gone through the printed questions, so now I'm just going to go to the chat. We've got about 14 or 15 questions in here. Are you doing surgery for trunk or breast without arm lymphedema?
The answer is we haven't yet. It's much less common. We've done it for people with scrotal lymphedema is similar. We've done that, penile lymphedema. We've certainly seen the odd patient who has subjective breast lymphedema after extensive surgery. Because of the way that the trunk drains, it has multiple different paths that it can drain. It's much less common. It's sort of like head and neck lymphedema. It can occur, but it's very uncommon. So we've really, I mean, we'll see anybody and we'll discuss what the options might be, but it would really, we would have to have a good understanding of the situation and be able to provide them a reasonable option. So happy to see them, but I just don't. It just hasn't come up.
Okay, great. Thank you. This is a question from a therapist. Who should we refer to you as a possible candidate for surgery?
Anyone who would potentially be interested in that and they feel that they're not managing adequately with the current path that they're on. We have no specific restrictions. I mean, I guess I would just say if somebody's not interested, it's probably not worth their time and effort to come and see us. But otherwise, happy to see anyone. So
really, they would see a therapist first. They would understand about compression and exercise and the other things that you would do to manage your lymphedema, and maybe see Dr. Weiss to confirm that it's a lymphedema issue and not something else. Sounds perfect. Okay. This is from Michael Del Basso. Are you in touch with the doctors at the lymphedema clinic in Surrey and refer patients to them and vice versa? You know, I know Imran. I guess there really isn't a clinic. It's just Imran Rantanchi. And he is a great guy. I know him reasonably well. I don't know if they really have a clinic, but he's certainly hoping to. It was something that he did in his fellowship in New York and wants to develop this and provide that as a service. And I think that that's great. They are still working on some of the, just like us, it takes a long time to get all of the components in place to be able to provide this kind of care. And they're still working on some of those aspects. But I think that we'll see how they continue to progress, and happy to try to assist them in any way we can. I did talk to Dr. Rantanchi maybe a couple of months ago, and He is working on microsurgery techniques, but he's working mostly with the breast cancer patients and trying to stop them from getting lymphedema. And he told me that he's not accepting patients to be referred there to deal with lymphedema, except through what they're typically doing. There's also a physiotherapy lymphedema clinic that follows breast cancer patients there for a year after their surgery, and they measure their lymphedema limbs. And you are allowed to be referred to this physiotherapy lymphedema clinic at the Surrey Hospital. And they have a perometer that they measure your lymphedema, and they have recommendations on advice. They're physiotherapists. I don't know that they're necessarily manual lymph drainage therapists, but they do have a really good program as well.
Great.
And another question is, what is the success rate in debulking a limb when it's twice the size of the other limb?
Yeah, that's a tough question. It depends on the quality of the tissues. So historically, prior to liposuction, the treatment for an enlarged lymphodematous limb was something like a Charles procedure. Sorry, I'm still here in the OR, so you're occasionally going to hear more stuff going on. Which is very deforming. The changes are very dramatic. So we even in more challenging cases, we like to use liposuction because it's less horrendous for the individual to recover from and how it looks afterwards. We certainly have reduced some people by many liters on one limb, so we can make things a whole bunch smaller. You know, we're willing to embark upon that and try our very best to get things as close as possible to the other side.
While we're talking liposuction, can you just explain the difference between SAPL and regular liposuction, so that if people have lymphedema and they have a larger limb, that they just don't go anywhere for liposuction?
Yeah, it's difficult to know. I had to go and look at some of this literature, particularly the area of water jet liposuction for lymphedema, or lymph preserving liposuction for lymphedema, for some other provinces. And I would say honestly that there's very little evidence to support one type of liposuction versus another. When I say very little, I couldn't find any that would suggest that any one particular technique is better than another. Most of the time you hear these claims from people who have a vested interest in you coming to their clinic. So I think that basically there are some technical, I mean, just as a general rule, liposuction of extremities is much more challenging than liposuction of the trunk. So that's just a general thing, whether it's for aesthetic reasons or for lymphedema or other reasons. But I think it just needs to be done in a thoughtful way, and then the post-operative management also is a very important component of the care of the individual.
Thank you. Are there other surgeons in BC that can perform SAPL? And if not, what is the reason?
Well, I think that the main reason that people don't want to do this is it's real work, and they don't necessarily get paid very well for it, particularly compared to doing aesthetic liposuction. We've encouraged many surgeons to consider this, but it just doesn't seem to be there doesn't seem to be a lot of buy-in.
Thank you. What is the waiting time to get an appointment with you? Do I have to go through Dr. Weiss when my internist is sending a referral?
So again, I will say, I look at all of these referrals, everything that gets sent in. I look at each and every one of them, and some of the referrals are honestly just not adequate. In other words, this person is 300 pounds. and they have heart troubles, but I think they might have some lymphedema too. It's just there are so many referrals like this that when we assess them, we do lymphoscintigraphy, they do not have lymphedema, but and I'm not saying that's the case for the person who asked the question, but it's because of the challenges that we experience, we really, we're so overwhelmed with people who don't have lymphedema that we're trying to weed them out so that the people with lymphedema can receive more timely care. And this is a difficult area. Most plastic surgeons, most internists are not going to understand the process of diagnosing someone with lymphedema. And it's not to say that they're bad people or stupid or any of these things. It's just not something that it's a common part of our education and our understanding. And as a result, many people think that any swollen limb is lymphedema, and that's simply just not the case. So that's the challenge. And I can appreciate it's very frustrating to think, why am I waiting so long? And patients, when I see them, they often say, why is your wait so long? And I get referred a lot of patients with a lot of problems. So it's hard. I'm just trying to make sure that people are seeing it in the fastest possible time. And as I hope we bring more of my colleagues in to this space, that will help the process as well.
And that's a good lead into the next question is, how can we help to get more medical professionals, doctors, surgeons, physiotherapists interested in treating lymphedema?
I haven't the foggiest. I wish I knew. I wish I knew. It's I think, from my perspective, how I engage my colleagues with this is by letting them know that it's interesting surgery and that we have an opportunity for improving the quality of life for patients. That's what they're interested in. So I'm trying to convey that, and it also matches well with some of their practices. Again, so for me, I've been a microsurgeon my whole practice, but the other part of my work is not lymphedema. So I'm trying to encourage, is not something that leads to a lot of lymphedema. Whereas my colleagues, Dr. Isaac and some of my new colleagues, they're breast surgeons. So this is a very natural addition to their practices. So I'm hopeful that if they do this, it'll help.
Dr. Vitanchi mentioned that 10 years ago, when he tried to get people interested in the microsurgery, there wasn't that many, and there's at least more people coming on now. And Dr. Key, who's a physiatrist as well, newer than Dr. Weiss, has said he's going to try and go and present to new physiatrists coming out of training. So advocating, one of the things the BC Lymphedema Association is trying to do is to advocate for coverage for lymphedema, but also throw out some more education as much as possible. And Dr. Brown, if there's anything else that we can do to help, please let us know. The next question is from a therapist as well. What are the pre-op requirements and post-op protocols for patients for your procedures?
So for, it depends on the specific surgery. So for LVA, we do immediate compression afterwards. You just go back to having fairly significant compression right away. So that's fairly straightforward. For vascularized lymph node transfers, we have compression up to the area of where the flap has been done. And then we don't do compression above that for the first 6 weeks, and then we resume compression. I would also say with vascularized lymph node transfers, you're in hospital about a week. With LVA, you can go home the same day. Liposuction, you're compressed immediately after surgery, and that really needs to be very significant compression for about 2 to 3 months before you can even get back into your formal garments again. And you are in the hospital. Sometimes if it's an arm, you might have it as daycare surgery. If it's a leg or more you might spend a night or two in the hospital. Part of that for pain relief, and part of that just because of the large amounts of fluid that can leak out.
Thank you. In terms of compression, do you have like a therapist that works with you that helps your patients? Is it custom compression that they have to purchase in advance?
No, so early on, we don't do custom compression early because the limb will swell and change so much. And we put on some special garments in the operating room. And once those are changed, then I've tried to use 2B grips, which the occupational therapist can help fabricate for us, and then supplement that with tensor bandages. But they're ideally, we'll try to get people back to see Dr. Weiss to do formal wrapping, which is a better option for the first couple months after these kind of surgeries.
Thank you. Here's a question from Andrea. I have been diagnosed by Dr. Weiss as having both lymphedema, I think she means lipedema, and overweight. Was told no point in dieting, as I have found to be the case. So what do you recommend?
I'm not an expert in lipedema, but I had to gather some information again for another province on this topic. There is some difference in opinion, but I use the current Canadian guidelines and the current European guidelines, and I would say those suggest that your best treatment option is bariatric surgery. They show the biggest impact for improving people's health and the size of their limbs. Dieting in general for people who have troubles with obesity is extremely low yield. They just do not achieve good outcomes, and the best opportunities for improving their health is bariatric surgery, which is again totally outside my area of expertise, but that was what the best available evidence is in 2023.
Thank you. Do you perform lymph node to vein anastomosis, and can you discuss the outcomes with that?
So the way that lymph node transfers work, you hook up the artery and the vein. It's sort of so a large amount of the surgeries that I've done for this kind of work over the long term is where I think of them as tissue transplantation. So we're taking tissue from one part of your body and moving it to another part. Often that's to reconstruct after cancer surgery or trauma or something else where you're missing something important. The vascularized lymph node transfer is very similar. We're just taking tissue from one part of your body and moving it to another. And we hook up the artery and the vein under the microscope. But the actual lymphatics are not hooked up. We rely on lymphangiogenesis, or the pumping function of that tissue, to help take the fluid out. So there is no attachment of the lymphatic to the vein. It's just the artery and the vein of that tissue.
Okay, I'm hoping that answers that person's question. I think we answered this other one. Is lymphedema liposuction different from regular liposuction? Here's another question. I have a vascular issue that prevents a required surgery as well as lymphedema. Which doctor should the referral be sent to?
So vascular problem, it could be either the arteries or the veins, and it will a vascular surgeon will be able to help determine what that is, and then if they have concerns beyond that, then we're happy to see them as well. So
go to Dr. Weiss first, and then.
No, I would say if you have a vascular problem, see a vascular surgeon
first. Okay. Do you do liposuction on 2 separate surgeries for legs, upper or lower, or both in the same surgery day?
We try to do everything at once.
Okay. Should one take water pills or other diuretics?
No.
Do you do thin flap lymph node transfer on the leg and higher up the leg rather than at the ankle?
Yeah, that's an interesting idea. I think again, the best evidence is using this tissue from your abdomen. It has it seems to work the best, and it gives you basically zero chance of getting lymphedema somewhere else, which would be very bad. And we do those now. Again, the best evidence today, that may be different tomorrow, is that we do them at the level of the elbow down or the level of the knee down. So that you don't have to have a skin graft on it. We originally thought that all of these things had to be done very distally, but they seem to work adequately at that level. But that's what I know today.
Yeah, things change in this world, don't they? Okay, this is from Kiara Singh, who's actually at the Surrey Physiotherapy Clinic, and she just wants to confirm. The Surrey Physiotherapy Clinic is a prospective monitoring clinic for breast surgery patients for all issues related to breast surgery at Surrey Memorial Hospital, not just lymphedema. So for post-surgical lymphedema, they offer education, exercise, and compression for a limited duration. The approach is a self-management approach. Thanks, Kiara, for just clarifying that. I've probably got about 6 more questions, and we've got about 4 more minutes, so we'll go through these. With congenital lymphedema, lower legs, is it best to see you before or after pregnancy?
I don't think it should make a big difference.
Thank you. This is from Paulette. I was referred to you about 2 years ago by my GP, but haven't heard anything. Should I assume the referral's looked at, or should I follow up?
No, you should follow up. If it's been 2 years, you should follow up.
Thank you. If there was imaging done in other health regions, would that speed up referrals to your clinic, as it would confirm if it was lymphedema or another condition?
Yeah, lymphoscintigraphy is very helpful to get that done. We initially found that the quality was best at St. Paul's, but I think that will also continue to improve elsewhere. So if you're able to get that done, that will help expedite things.
Great. Do you have a referral form so that we can submit correct and adequate information to help?
No, we don't have a specific form, but that's something, I guess that would be a good action item for us to work on.
Okay. Is the post-surgery compression covered under the health plan?
Yeah, but it is some of it is for sure. Like 2B grips are covered, the tensor bandages and things that I apply are covered, but ultimately you need something better. This is just temporizing things.
So yeah, for the follow-on, you'll go back to your compression garments or the other
That's correct.
That prior.
Yeah.
How do you track the success of the clinic in treating patients? Do you follow up post-surgery over the long term?
Oh goodness, yeah, we follow up lots, but we also have a database for collecting all of this information.
That's good. And I think we've gotten to the end of our questions, and it's 5:59, or did I go way too long? No, we're on time, right?
You're perfect.
So if people have more questions down the road, please send them to the BC Lymphedema Association, and we'll try and get in touch with Dr. Brown. We also have a Lymphedema Education Day coming up March 2nd, 2024 in Port Moody. So put that on your calendar. We don't have it advertised yet, but just so that you know. And we have more webinars coming up in the next couple of months. So just really appreciate your time, Dr. Brown, answering these questions for us. And for those people that couldn't make it, we will share the recording up there.
Thank you for taking the time, and we really do want this to be successful and to try to continue to improve the care for people with lymphedema in BC.
Thank you. And anything that we can do at the BC Lymphedema Association to help you out with that would be great.
The suggestion for a referral form was great. We'll work on that.
Okay, great. Thank you.
Good night, everyone.